Hello, and welcome to this Clinical Care Options podcast episode. This episode is a featured component of an educational program titled A New Way to Low, Targeting Residual Inflammatory Risk in ASCVD and CKD. I'm your host, Kim Neely, and today I'm excited to be joined by amazing faculty experts. Dr. Erin Michos is a professor of medicine, director of women's cardiovascular health, and associate director of preventive cardiology at Johns Hopkins University School of Medicine. We also have with us Dr. Mark Sarnak, professor of medicine at Tufts University School of Medicine and chief of the Division of Nephrology at Tufts Medical Center. To find more activities on targeting residual inflammatory risk in ASCVD and CKD, including a CME certified text module with animated video and faculty voice audio clips, clinical thought commentaries, and more, visit clinicaloptions.com or visit the link in the show notes. Now I'm excited to hand it over to our guests.
Welcome. So we'll be talking about inflammation today. Inflammation, of course, can be beneficial. It's evolved to promote survival, but inflammation can be maladaptive when chronically activated and sustained, leading to tissue injury. And every step of atherosclerosis, from the development of endothelial cell dysfunction to foam cell formation, to plaque formation, to ultimately plaque rupture, is driven by cytokines and interleukins and the components of an inflammatory response. So you need ApoB lipoproteins, cholesterol, for initiation of plaque. When you have too many lipoprotein particles, they migrate into the artery wall. So we still have to, of course, address LDL cholesterol and ApoB. However, at the inception of atherosclerotic lesions, this endothelial dysfunction and the subintimal cholesterol accumulation ignites an inflammatory response. There's upregulation of adhesion molecules, and that promotes more transmigration of inflammatory cells, such as monocytes and T cells, into these early plaque sites. And then these infiltrating monocytes become resident macrophages as they take up lipids, and then they become foam cells. And upon activation, a subset of these neutrophils are going to assemble to form a multi-protein complex called the NLR3P inflammasome. And we're going to talk more about this at upcoming podcasts, but the NLRP3 inflammasome activates pro-IL-1 beta to the biologically active IL-1 beta. And interleukin-1 beta then promotes downstream production of the cytokines TNF alpha and interleukin-6. And then in turn, interleukin-6 induces hepatic production of these acute phase reactants like C-reactive protein. So likely C-reactive protein is not causally related to atherosclerotic cardiovascular disease, but it's a really good biomarker we can measure in our patients because it's stable in blood for a long time and has a half-life of 20 hours. And it's a really good integrator, a really good marker of this aforementioned immune activation. And we know that inflammation is very common in our patients who have both kidney disease and cardiovascular disease. A recent analysis of baseline CRP levels in participants from the SELECT, SOUL, and FLOW trials showed that in persons who have cardiovascular disease, CKD, and diabetes, with or without overweight or obesity, about 50% had elevated C-reactive protein levels above 2. So systemic inflammation is very common in this population, and which is why, as cardiologists, encourage everybody to measure CRP to assess and address a risk. But now I'm going to turn it over to Dr. Sarnak to talk about inflammation in the kidney and the role of the nephrologist in screening and mitigating systemic inflammation.
Thank you, Dr. Michos. As you mentioned, it's pretty well recognized that there's a very high cardiovascular risk in patients with CKD. And the types of cardiovascular disease that occur in patients with CKD are multiple. It may be atherosclerosis, it could be cardiomyopathy, it could be arteriosclerosis. And there are many risk factors for development of these various types of cardiovascular disease. And there are many things we intervene on as nephrologists to try and reduce this cardiovascular risk. So when we think about outcomes in patients with CKD, we think about two primary outcomes. The one is progression of kidney disease, and the second is development of cardiovascular disease. I think it's well recognized, as you alluded to, that there's high levels of inflammatory markers in patients with CKD. And this could be, measured by CRP, or it could be IL-6 levels. I think as your GFR drops, in most analyses, we've found that CRP levels or IL-6 levels increase. I think there's also pretty good data that IL-6 levels and CRP levels are risk factors for development of cardiovascular disease in patients with CKD. Although from the basic science data, we clearly know that inflammation is playing a big role in progression of CKD. I think there's probably less epidemiological data relating biomarkers to progression of CKD, but I think the general consensus is that inflammation is playing a role in progression of CKD as well. As nephrologists, I would say we're not routinely screening for inflammation currently. I don't think our guidelines currently recommend screening for inflammation. We do definitely treat lipids, and we'll talk about that a little bit more in the following podcast. And although we recognize that treatment of the lipids, there's still residual risk, currently we're not routinely measuring CRP in our patients. In patients who are over the age of 50 who have CKD, we routinely treat them with statins to reduce cardiovascular risk. But I think the reason we're probably not screening is because it's probably not going to change how we take care of the patient. We just don't have the agents that are particularly focused on inflammation that will reduce cardiovascular risk.
Right. Even in the cardiology guidelines too, there hasn't been strong recommendations to measure inflammatory markers like CRP, which I think is really a lost opportunity. Currently, the guidelines give a role in primary prevention for patients who don't have established cardiovascular disease, trying to identify those who are at risk. And C-reactive protein is considered a risk-enhancing factor. If it's above level of 2, that would favor the initiation of a statin in primary prevention or intensification. And that was really based on the Jupiter trial of primary prevention patients who had relatively normal LDL cholesterol, but high CRP, and showed a strong benefit for reducing cardiovascular events, as well as all-cause mortality with rosuvastatin. So the guidelines do play a role of considering CRP and primary prevention as part of risk stratification, and some of the risk scores include CRP, like the Reynolds risk score. But I think we should also be considering measuring it in secondary prevention. And many clinicians, feel like, why measure it in secondary prevention? Our patients are already treated with statins in secondary prevention. But we know that even in statin-treated patients, that residual inflammation, residual risk due to inflammation is captured by a CRP above 2, strongly is associated with future risk of cardiovascular events and cardiovascular mortality, even in patients whose LDL is well controlled on statin therapy. And now, we have other therapies that we can add, like in secondary prevention. We're going to be talking about colchicine in a later podcast. But, because events still occur in statin-treated patients, we call this residual risk. I like to measure CRP because if it's elevated, I may be thinking about adding colchicine in patients with chronic coronary disease. So I encourage clinicians to think about inflammation and to measure CRP both in the primary and secondary prevention settings.
Yeah, I think one of the challenges in kidney disease, as I've said, is we have many risk factors that will help us predict a higher risk of outcome. And because everyone with CKD, based on our most recent KDIGO guidelines, although it is quite a long time ago, it is treated with a statin to the optimal dose, it won't necessarily change how we take care of the patient. It is possible that people are not following the guidelines and maybe not pushing the statins as much as they should. But I think this is an exciting area for us because we realize the residual renal risk and inflammation is clearly one of the powerful risk factors, independent of your reaching lipid targets. So if we have new agents to treat this residual risk, this will be a big addition to our armamentarium. Yeah, so I do see that in the future, as we learn more about inflammation and have potential treatments, I think people will definitely start measuring these inflammatory markers, CRP obviously being the easiest one to measure, more routinely. I mean, once hopefully we have positive data. I think in kidney disease, it's been an exciting period over the last 5 years, and we're seeing a lot of trials that are showing benefits, and benefits completely independent of inflammation. At least several of the treatments that we're using are presumably acting independent of inflammation. So I think if trials show benefit, our guidelines will change and practice will change. I think we, as nephrologists, really follow the trials.
So I mentioned the cardiology, the American Heart Association, American College of Cardiology primary prevention guideline that considers CRP a risk-enhancing factor. And I also want to note that they also highlighted autoimmune diseases like rheumatoid arthritis, lupus, psoriatic arthritis, HIV infection as also being risk-enhancing factors. Because we know that these individuals that have these autoimmune inflammatory conditions are at high risk for cardiovascular disease, and there's even a lipid paradox where they develop atherosclerotic cardiovascular disease at, apparently lower LDL levels than what we see maybe in the general population. And so really be thinking about intensive preventive treatment in these groups. So in upcoming podcasts, of course, we're going to talk about targeted anti-inflammatory therapies for atherosclerosis, but I also want to emphasize, of course, the fundamental lifestyle modifications directed at diet, weight loss, exercise, smoking cessation, all of which lower vascular inflammation and lower cardiovascular events. And some of the therapies specifically, in addition to lifestyle, but targeting weight management, such as GLP-1 receptor agonists, also lower C-reactive protein. So, inflammation can be a bystander associated with, cardiometabolic diseases, metabolic syndrome, visceral adiposity. But again, I think we have really good data now suggesting that inflammation doesn't just keep company with other associated cardiovascular risk factors, but in and of itself likely is causally related to ASCVD and thus a potential target for treatment in and of itself.
Yeah, I completely agree with that. I mean, in kidney disease, there are a lot of lifestyle modifications, particularly avoiding high sodium diet, things like this that promote hypertension, that promote vascular disease. And recent studies obviously showing, particularly in patients with CKD, GLP-1 agonist benefits, as well as a lot of other novel agents that have benefits in CKD.
Well, I think this is a good summary to start us off about the role of inflammation in cardiovascular disease and kidney disease. And stay tuned for our other podcasts where we're going to discuss moving beyond lipid lowering and focusing on residual inflammatory risk and talking about these new and emerging anti-inflammatory agents that we've alluded to for managing cardiovascular risk in patients with kidney disease. Thank you.
Thank you.
Thank you so much to Dr. Michos and Dr. Sarnak for joining us for this very important discussion about addressing residual inflammatory risk in patients with ASCVD and CKD to improve outcomes. And thank you for listening. As a reminder, visit the episode notes or clinicaloptions.com to find more educational activities.